The topic I'll be presenting to you today is the treatment options for common hand and wrist conditions. And thank you very much for your attendance on this virtual seminar. I really appreciate it. So I have nothing to disclose, unfortunately. So I'll start off with a brief overview of the presentation. We'll start to talk about the basic hand exam and the usual way I evaluate patients for common hand conditions. We'll review some basic traumatic injuries, including distal radius fractures, scaphoid fractures, as well as mallet fingers. We'll also talk about very common disorders of the tendons called tendinopathies, specifically de Quervain's tenosynovitis and tennis elbow. We'll also discuss a very common compression of the nerves in the arm called carpal tunnel syndrome, as well as cubital tunnel syndrome. And we'll also talk about some common masses in the hands that we excise. And we'll also touch on some arthritis of the hands and fingers and review the treatment options for those. So my approach to a patient is, for each patient, I approach everyone in a very similar fashion. I want to know what brings them to the office. And this is critical to understanding and developing an accurate diagnosis. So HPI means history of present illness. I want to know the location, intensity, duration, frequency, radiation, and associated symptoms of pain. Each patient is different, and patient demographics are critical to establishing the diagnosis, an appropriate treatment plan. I evaluate each patient's past medical history and past surgical history for things like diabetes, rheumatoid arthritis, kidney disease, thyroid disease, heart disease, as well as skin disorders. We'll also ask specific questions related to specific diagnoses, specifically Dupuytren's, which I'll touch base on later. Social history is also critical, whether or not the patient is a smoker, uses alcohol, etc. Very important to my examination is whether this is a progressive kind of insult, or was there a recent trauma, such as a fall or motor vehicle accident. We look for pain, deformity, range of motion, as well as weakness, numbness, or instability in the hand and wrist. Physical exam is critical. So the first step is inspection, looking at a patient's hands or forearms and elbow as they're swelling, redness or infection. Palpation is key, putting pressure on certain areas and evaluating each bone or ligament or tendon is critical to how I approach each patient. I assess active and passive range of motion, as well as perform a full motor and sensory examination, as well as special tests for special diagnoses. Again, inspection is critical, and luckily in hand surgery, we have a built-in comparison to the other side. We look at perfusion, pulse examination, as well as color of the fingertips. Since sensory exam and motor function are a critical part of this, we also do a full tendon examination and look at the motion that each tendon provides. Skin examination, looking for wounds, swelling, scars are all critical. And we also look at swelling, obvious deformity, and those types of things. Again, palpation is critical. It helps us to localize where your pain is and what the possible injury can be. Range of motion is also a critical part of the exam. We look at the active motion that you can do, the passive motion that is possible with each digit, as well as limitations. Is there pain? Is there swelling? Is there bone spurs or something like that that may be preventing full range of motion? And these are all recorded so that we can compare them to later. Whether or not there's surgery or conservative treatment, we want to know that we get your function back to the best it could possibly be. Muscle strength, motor function is critical to your functional life and activities of daily living. So we want to make sure that you're you have the best function you have. So look at motion in all the joints, whether or not you can make a full fist and extend the wrist and strain the fingers. A sensory exam, there's a slew of diagnoses that can cause deficits in your sensation, whether or not it's a compression of the nerve or secondary to diabetes and peripheral neuropathy. And those are all tested very carefully, especially in the hand, looking whether or not you could finally discriminate between 2 points, and a full evaluation of this is performed to further assess and diagnose. One of the most important nerves in the hand and wrist is the median nerve. And this is what, when it's compressed, causes carpal tunnel syndrome. The median nerve, it innervates, which means it supplies function to both motor function as well as sensation. And the motor nerves that this provides are the wrist flexors, so flexion of the wrist, the finger flexors, as well as some of the fine muscles in the hands. And we check that with an AOK sign. Also, when there's symptoms like carpal tunnel, one of the muscles can be weak. So it's always important for us to test those. The sensory exam for the median nerve is listed there in blue. It's what we call the radial 3.5 digits, so the thumb, index, middle, and part of the ring finger. Those will be decreased with sensation during carpal tunnel syndrome, which we will discuss a little bit more in future slides. The ulnar nerve is a very important nerve, and when that is compressed at the elbow, it's called cubital tunnel, and if it's compressed at the wrist, that's called ulnar tunnel syndrome. And that nerve is important because it innervates or supplies muscle function to some of the fine finger movements, especially the ring and small finger, as well as some finer muscles in the hand. The sensation that the ulnar nerve supplies is on the ulnar aspect of the finger, or the part of the ring finger and part of the pinky, as well as on part of the back of the hand. That's shown there in kind of the yellow color. And the last major nerve in the hand is the radial nerve. And this supplies function to allow for wrist extension, finger extension, and thumb extension. It also provides innervation for sensation at the back of the hand, specifically those shown in red on your screen on the back of the thumb, the first web space in the hand. So when there's compression of the nerve, there could be a slew of findings, either sensory or just pain. And these are covered later on. Critical to the examination is to look at the pulses. And, it's not just adequate to look at the radial artery and the ulnar artery, but whether or not they're patent and they provide flow. This is mostly important for surgical interventions. This test is not always performed. Traumatic injuries are really common with hand surgery. These open injuries, which means there's a laceration, may just be superficial involving the skin, but occasionally they can result in injury to the nerves, blood vessels, tendons, muscles, bones, and joints. So we do a careful examination, including radiographs, to look at the full extent of the injury, the possible requirements for surgery, or whether or not this can be treated non-operatively. Usually, these are treated with just some cleaning or irrigation and debridement, which just means cleaning the soft tissues. And for the most part, they're just loosely approximated with sutures, either in the office and depending on severity in the emergency room or the operating room. Usually, depending on the type of laceration, if there's a rusty nail involved or a metal object, we do recommend some tetanus immunizations as well as antibiotics. And early referral is key to a successful recovery from these injuries. So I always like to see my patients that have these types of injuries very soon. Moving on to hand and wrist trauma, very common injuries that we see on a daily basis include distal radius fractures, scaphoid fractures, metacarpal neck fractures, as well as mallet injuries. And we'll discuss each of these. Distal radius fractures are very common. They usually occur due to a foosh injury or fall onto an outstretched hand. as depicted in that cartoon. There's a classification system of these types of injuries, which we won't cover, but there's a slew of them that provide us some guidance as to whether or not we need to do surgery. At the time of injury, with careful examination, inspection, and radiographs, we look at other injuries that are commonly associated with these types of fractures. Those include the ulnar styloid, different bones in the wrist called the scaphoid or carpal bones. And we also look at whether or not these are due to an open injury where there's bleeding or exposed bone, or whether or not they're closed without laceration. Another important aspect of these fractures are whether or not they involve the joint, and that's called an intra-articular fracture. And this may push us more to a surgical intervention rather than non-operative treatment. There are complications that we look for on our early examinations, including carpal tunnel syndrome, which can happen due to increased swelling and compression of the median nerve. So we'll look for that very carefully. In the intermediate term, if this is treated non-operatively or operatively, we look at the function of the tendons because they can be involved over the course of several weeks after initial injury. At the late term, several weeks to months after injury, we always look for stiffness and limitations with range of motion and whether or not there's a malunion, which means that the bone did not heal in the proper location or alignment. In my assessment for surgery, I look for several findings, whether or not the bone is shortened, whether or not there's inclination loss or angulation loss, or whether or not the fracture goes into the joint. So most of the time, these fractures can be treated conservatively without surgery, or they can be manipulated in the office or in the emergency room into a better location where they can be treated without surgery. If the fractures are non-displaced or they are well reduced, which means they are manipulated into a good position that is acceptable, we will treat that in a splint and then followed by a cast. Another finding that might be important is whether or not this is a non-dominant hand. Taken as a whole, as well as patient demographics, we assess the need for surgery. And for the most part, at this day and age, most of these are treated with open reduction and torn fixation. That's what's listed there as ORIF, where we put plates and screws inside and put the bone back into a better alignment and fix it there. And the goal with that surgery is to get your wrist moving so we have the best possible functional outcome in terms of range of motion, strength, and pain. Occasionally, if the fractures are really bad, where they're in multiple pieces, or they're not amenable to a plate and screws, we'll do something called an external fixator or a bridge plate, which are a little bit less common, but in high energy traumas like a fall from a very high distance or a high velocity trauma like a motorcycle accident, we have to do those. So those are all just tools in our armamentarium to appropriately address your fractures. The next bone that's a very common injury that is easily missed is a scaphoid fracture, and that's evident in the top right image with the white arrow. These are easily missed because they're often treated as a sprain. So anytime a patient says they have a sprained wrist, I have a high index of suspicion for this, and I get radiographs to fully assess this. Oftentimes we need CAT scans or even an MRI to determine whether or not there's a broken bone there. But for the most part, we rely on examination, such as tenderness to palpation or specific maneuvers to assess, do we need to go further with advanced imaging? The problem with this fracture is that it's at risk for what we call non-union, or it doesn't heal, because this bone has a vascular spot that can be compromised depending on the location. So it's something that we treat very seriously. If this goes on to what we call non-union, or it does not heal, it could be a devastating issue to the wrist down the road with arthritis and significant pain requiring fusion surgery. So it's something we take very seriously. And we start off with radiographs, looking exactly for these fractures, but occasionally we need to go on to more advanced imaging like an MRI or CAT scan. If the patient's painful and negative, and radiographs are negative, we'll start off with just some immobilization in the splint and recheck x-rays at a later time point, and as well as the examination. If it's non-displaced, conservative management is always indicated. There are a few instances where we would treat a non-displaced fracture with a screw, but those are special cases. And usually a cast is placed for oftentimes 6 to 12 weeks until it's healed. And that time frame depends on the location of the injury as well as the patient's examination, whether or not they're still having pain. If this needs surgery, these usually are due to, there's the displacement of more than 1 millimeter on x-ray, or there's some issue with alignment that is not acceptable. So that's usually fixed with the screw, and occasionally we need to do a bone graft procedure to augment that. And fractures are really common, and for the most part are treated conservatively. They can occur in any of these bones, but most commonly the metacarpal bones, head, neck, and shaft are the most commonly injured. We'll discuss a few select topics there. For the most part, these injuries can be classified as stable, but there are some unstable fractures that need surgery, and we'll discuss those as well. The problem with hand fractures is we cannot accept any type of rotational deformity, because if you make a fist and there's some crossover of the fingers, or you're not able to make a fist, it leads to functional problems. So we address those with surgery, or reduction in stabilization with the splinter cast. The goal with hand surgery is to get you moving as fast as possible so that we prevent stiffness, which is really common with a lot of the finger joints. Metacarpal neck fractures, or more commonly known as boxer's fractures, especially in the small finger, are due to a boxer's load to the metacarpal phalangeal joint, which is the knuckle here. These are really forgiving fractures. We can accept a lot of angulation, up to 50 to 60 degrees in some literature, in the small finger. These are really common fractures. They're painful, they're swollen, and when I see patients with these fractures, I look for displacement, whether or not they're very angulated, whether the fracture looks stable, as well as if there's any rotational deformity. Most of the time, these are treated with what we call a closed reduction, where I manipulate the bone and place it into a splint in a better alignment. And these fractures usually tend to heal pretty quickly, about 4 to 6 weeks, if the alignment is acceptable. And we can pretty much get you moving as soon as possible. If there's acceptable alignment, if it's out of the joint, it's not very angulated, these are all that can be treated conservatively, but occasionally with multiple fractures or rotational deformity where there's crossover. These can be treated with a slew of different options, including pins, screws, plates and screws, as well as intramedullary nails, which are very becoming into fashion currently. Mallet fingers are really common. If you look at any basketball player, it's likely to have one of these. NBA players, they all have mallet fingers. This is due to a sudden force to the end of the fingertip, causing pain and inability to extend at the DIP joint, as shown in those cartoons. These injuries can be due to a fracture, or they could be due to just a tendon injury. For the most part, these are closed injuries, but occasionally they can be due to a laceration or a cut to the tendon. And the joint can be either reduced or dislocated, and all these factors enable us to make a decision whether or not you need surgery. For the most part, these are treated without surgery. Pure tendon injuries can be treated with 6 to 8 weeks of splinting, followed by nighttime splinting and a very certain protocol to get your function back to where it was. Oftentimes, you will have some component of what we call an extensor lag, where you can't fully extend the digit, or there's just a little bit of deformity, which is totally acceptable. If the injury occurs, 8 to 12 weeks prior to presentation to me, we will try splinting as shown for the acute injuries, but it can, unfortunately, these do tend to recur. If there's a fracture, this oftentimes can be treated without surgery, just like the tendon injury variety of the Mallet Fingers. But if there's a big fracture involving a lot of the joint, or the joint is not aligned properly, we will often advocate for pinning of the joint. And that usually stays in for about 4 to 6 weeks, depending on the injury and the surgeon's preference. Very occasionally do we have to make an incision and repair the tendon, and that's very rare. The next subject that we'll talk about is tendinopathy. It's something that's near and dear to my heart, something I spent a lot of time in my research evaluating and studying. So we'll just discuss some terms that you might hear, and those include tendinitis and tendinosis, which basically means inflammation of the actual tendon. Tenosynovitis is a subset of tendinopathy, and that means inflammation of the tendon sheath, or the sheath that surrounds the tendon. And those are, tenosynovitis is very common in patients with rheumatoid arthritis, overuse injuries, and occasionally can be infectious in nature, which is usually a surgical emergency. Two very common tendinopathies I'll discuss is de Quervain's, as well as lateral epicondylitis. So de Quervain's tenosynovitis very commonly occurs in a new mother for reasons that are somewhat unclear, but the classic story is a new mother that's taking care of her new child starts to have pain over the radial aspect of the wrist, on the outside of the wrist, and tender over a part of the wrist that has two tendons that pass through a tendon sheath. And so during the examination for this, I looked at two tests called Finkelstein's and Eichhoff's, and that basically reproduces and causes strain on that compartment very reliably. And if there's pain there, it can consistently determine whether or not you have this type of injury to the tendon sheath. The treatment for this is rest, ice, compression, and elevation. Medications that we sometimes try are anti-inflammatories like Advil or Aleve, ibuprofen, and occasionally steroids, usually in the form of corticosteroid injections to that area. Sometimes we'll treat this with special splints that keep the thumb extended, relieving and offsetting stress on that area, as well as occupational therapy, stretching, and massage. Surgery is very rare for this, but it is very effective. And this is in the form of compartment release, where we go in and make an incision over that compartment to release the tendons and offload compression of those tendons. Tendinopathy, specifically tennis elbow in the form of lateral epicondylitis, and this is caused by very small micro tears, as shown in that cartoon on the right, of the tendon origin of the muscle called the extensor carpi radialis brevis. And this can be caused due to repetitive actions like a backhand swing of in tennis or repetitive hammering. And this will present commonly with pain over the lateral epicondyle or part of the elbow where this tendon inserts, as well as specific maneuvers where we look for resisted wrist extension to see if we can put more stress on that area to elicit pain. Very common theme is treatment for this is rest, ice, compression, and elevation. Medications we utilize are Advil, Aleve, non-steroidal anti-inflammatories, as well as steroid injections to this area. Counterforce bracing as well as wrist splinting are advocated to offload the stress on that. But also critical to treatment of this is occupational therapy. This tendinopathy is known to last several months. It takes dedication and patience to heal fully. Injections are very commonly done, and they do provide significant relief and can get you over that that hump to get you moving with home exercise as well as therapy. Surgery for this is very rare as well. That's where we go in and either debride the area, which means clean up the tissue that's diseased and possibly repair or tack it back down to where it's supposed to be. And very rarely do you have to do a bony procedure for this type of injury. The most common issue relating to tendinopathy or tenosynovitis in the hand surgeon's practice is going to be the trigger finger. And this is due to stenosing tenosynovitis, which is just a fancy term for compression around the tendon of the flexor tendons in the hand that is causing pain, as well as locking or triggering. So in this injury, the flexor tendons have a pulley that gets inflamed as well as thickened. Now, oftentimes a nodule forms. And so when a patient arrives with this, they'll have pain right over that pulley, as well as possibly locking, triggering, clicking, as well as a palpable nodule or thickening of that tendon. Treatments for this, first line are always rest, ice, compression, elevation, stretching, and corticosteroid injections. Oftentimes we'll start out with that, and that's all a patient ever needs. Occasionally, surgery is advocated for, and it's one of the most common procedures we do, where we go in and make a small incision and release that pulley, which has no functional deficit to the hand. And it's a very effective procedure. In terms of deformities of the hands that we can see, these can be in the form of a boutonniere or Swanic, which we'll discuss, flexion contractures, which is very common, and that's called the Dupuytren's contractures, osteoarthritis, as well as rheumatoid arthritis. A boutonniere deformity is shown in the picture and cartoon on the right. And this happens when the PIP joint, or proximal interphalangeal joint of the finger, becomes flexed down, and the distal joint, or the distal interphalangeal joint, becomes extended. And this is oftentimes due to a rupture of one of the tendons on the back of the finger, called the central slip. And this is usually due to a resisted, forced hyperextension of the finger, and results in an inability to extend that joint in isolation, with some specific findings that we see. Predominantly, if these are acute, these can be treated with a splint that's similar to the one found on the right. And oftentimes, even chronic ones can be treated this way. A Swanic deformity is almost the opposite of the boutonniere, and this is shown in the picture on the left with hyperextension of the proximal interphalangeal joint. And this occurs due to a rupture of one of the ligamentous and capsular structures in the finger on the front, called the volar plate. So the hyperextension of this joint causes flexion of this joint. And these are commonly due to, and commonly seen in patients with rheumatoid arthritis or patients with a mallet injury like we discussed before, which can result in this. A topic that's very interesting to me is Dupuytren's. And this is totally a benign disease, which is characterized by nodules and contractures, as well as cords in the palm extending into the fingers. These are predominantly in male patients, but it can occur in females. And there is a genetic component to this. Usually patients present in their 50s to 70s. And if a patient presents in the earlier, this is usually resulting in a worse prognosis. Also, earlier occurrence occurs in patients with other problems located in their other parts of the body, such as the feet. Usually patients are of Northern European descent, and predominantly it occurs in the ring finger, but can occur in any finger, and in multiple fingers. there's a special cell in the body called the myofibroblast that's producing a different type of collagen under the skin, resulting in what we call cord formation, which eventually and slowly over time will cause these contractures of the fingers, as shown in the image on the right. Treatment options for this, there are quite a few. If there are no contractures and the patient's able to place their palm down on the table without issue, these are traditionally treated with observation. There is a significant amount of recurrence with these depending on the treatment, but usually we can rely on these figures, but there's a constellation of associated issues that may cause the recurrence to be higher or lower. Recurrence rate are in the literature show at 1 to 2 years after any type of treatment, they can recur up to 30%. At 3 to 5 years, 15%. At 5 to 10 years, 10%. And after 10 years, less than 10%. And these recurrence rates are higher with non-operative management, especially when the fingers are contracted with the small finger, as well as whether or not there's a constellation of symptoms in the body, including the involvement in other areas. In terms of conservative management, we start off with observation if there's no contractures, as well as stretching exercises. There is a newer treatment option called Xyaflex, which has been on the market for a few years. It's an enzyme that, when injected into the hand, breaks up the contractures, and after a few days, we manipulate the hand to try to obtain release of some of those contractures of the hand. This is not a panacea. It can reliably correct contractures that are mild. And also, if the contracture occurs at the metacarpal phalangeal joint, or MCP joint, it's a little bit better at fixing those contractures than when they affect the proximal interphalangeal joint. These injections do have side effects and they do have complications. Most commonly, skin tears in patients with severe contractures, pain. There are minimal reports of tendon ruptures, as well as pulley ruptures. Those complications are rare. There's another form of treatment that can be tried by some surgeons. I do not perform this procedure. It's called needle operotomy. This is indicated for mild contractures or if patients are not able to have surgery. The problem with this procedure is that they have a high recurrence rate and less improvement than with surgery. However, if there are specifics regarding each patient that may indicate this procedure over surgery. So it is an option. The mainstay of surgical options are resection and fasciectomy. There are various different approaches that have evolved over the decades, but currently the fasciectomy is most commonly performed. These are indicated for significant contractures. And if the other joints are affected in the fingers, oftentimes we have to do something to those to release those structures. Occasionally, when there's a lot of fingers involved, or this is a revision or repeat surgery, we have to do some skin grafting or other types of procedures. Hand arthritis is common. Osteoarthritis is one of the most common issues we treat. And for the most part, these are treated non-operatively. The distal interphalangeal joints, the end of the fingers, the PIP joints, the proximal interphalangeal joints, and the thumb, carpal, metacarpal joint are the most commonly affected with osteoarthritis. There's specific names to these. They're not totally critical, but with arthritis, other things can happen in the hand, such as with the distal interphalangeal joint. You can have something called a cyst formation, which we'll show in later slides. It can affect the nails, causing nail ridging. In terms of the other joints in the hand, it can begin to start causing contractures, loss of range of motion, loss of strength, as well as functional deficits. Rheumatoid arthritis is a different picture. They affect different joints predominantly, usually occurring at the wrist, metacarpal phalangeal joints, as well as occasionally the PIP joints. And there are different procedures for both of these issues. The mainstay treatment for this is conservative DIP joint. We observe these. We treat these with anti-inflammatories, occupational therapy, paraffin baths, Epsom salt baths, and steroid injections occasionally. If there is significant debilitating pain, we'll fuse these joints into a good position so that they're strong and usable, functional. They will lack motion though. If mucus cysts are present, observation again is the mainstay, as 20 to 60% of these will resolve. If there's an appearance of an infection or straining, where there's a significant bone spur, we will oftentimes advocate for surgery to remove the cyst as well as remove this bone spur to prevent recurrence, but these can recur, resulting in a need for further procedures such as a fusion. Osteoarthritis at the PIP joint is common, and we treat this with observation and anti-inflammatories. For the index and small fingers, it's usually indicated to fuse those joints to provide strength, especially with grip strength and pinch strength. For the middle and ring fingers, it is possible to do a joint replacement for those, which is commonly performed. Thumb carpal metacarpal joint arthritis is very common. This usually affects females more than males, and more commonly in Caucasians. Hand osteoarthritis more common in Native Americans, interestingly. And this is due to attenuation or slow decline of a special ligament in the hand called the anterior oblique ligament. If a patient's very young, it's possible to do a reconstruction if there's not a significant amount of arthritis set in. But as we age, the arthritic picture is shown in some of the images on the right, which show bone-on-bone arthritis with whitening of the joint on X-ray, which is a sign that the arthritis is set in, the cartilage is worn away. Something that we look for on each examination is whether or not there's an associated carpal tunnel syndrome, because that's associated with this, as well as a deformity at other joints in the hand, which may need to be addressed at the time of the treatment of the other predominant arthritis at the carpal metacarpal. Something that's an interesting fact is that joint provides or sees a force of about 13 times of anything that you pinch. So that's why this arthritis occurs there. On examination, we look at pain at that joint, at the base of the joint there, whether or not there's a deformity where there's extension at the adjacent joint, swelling, crepitus, something called a grind test where we load the joint and see if there's pain there. And those are really key to how we make our assessment. The treatment for these are usually conservative. If there's no pain or you're able to do everything that you want to do, we could treat these with anti-inflammatories, splinting such as the sleeve on the left, steroid injections, as well as anti-inflammatories. If a surgery is required because of debilitating pain, you're not able to get to where you want to be or your function is compromised, we do a surgery called an LRTI. And that's where we take the diseased bone out. That's called a trapeziectomy. And we reconstruct the joint with a tendon that's in your body. There are several different ways to skin a cat here and several different methods of doing this. And each surgeon has their own little technique and art form to this. And every patient is different, requiring a different subtle treatment options. So it's a very interesting topic and something that's changing and evolving over the decades in terms of standard of care. In terms of peripheral compressive neuropathies, this is when a nerve in the wrist or forearm or upper extremity is compressed and causing pain or swelling or numbness and tingling or loss of function. Localization is key. You need to know where it's occurring and where that compression is happening. The two most common issues that we deal with are carpal tunnel syndrome and cubital tunnel syndrome. This is due to compression of the nerve causing a blood supply issue to that nerve, resulting over time in fibrosis and just prolonged compression. In carpal tunnel syndrome, there's a compression of the median nerve at the wrist by the transverse carpal ligament. 1 in 10 Americans will be affected by this, whether or not they have surgery in their lifetime. And it's very common in females in a 4-to-1 ratio. And it's very common to see this in both hands. And this is usually present for months before presenting to a surgeon. Anytime a patient comes in with this, we look for whether or not there's associated conditions like diabetes, thyroid disorders, rheumatoid arthritis, or the patient's pregnant or peripartum, whether or not there's associated findings that there may be another injury someplace in the spine or further up in the arm. That's something called a double crush phenomenon, where there's more than one site where that nerve is compressed. For diagnosis, we look for numbness and tingling in the radial 3.5 digits, nighttime burning pain that's aggravated by activity, wakes up in the middle of the night, shaking the hand can relieve that pain, as well as weakness and clumsiness of the hand. Oftentimes, we do a nerve study to look at where that compression is, whether or not there's a double crush issue, or if there's something coming from the spine. There's a slew of diagnoses that may be associated with this. Don't let this worry you. Most commonly, there's none of these involved. It's just something for the surgeon to know to look for and to address. Carpal tunnel on examination, we look at a very important test. Tinels is where we percuss the nerve and see if there's numbness and tingling. We look at manual compression of whether that reproduces the symptoms, and what does the patient feel when we do these. We also look at a sensory exam to assess whether or not the nerves are affected, if the muscle is affected. The bottom left picture is a late finding where the nerve has been compressed for a long period of time or severely compressed, causing atrophy of the muscles, which is a very urgent requirement for surgery. Most of the time, these can be treated conservatively. If the symptoms are mild, they can respond to nighttime splinting in a wrist splint or to steroid injections, even occupational therapy, and modifying your activities, how you sleep. Surgery is usually reserved for carpal tunnel symptoms that are refractory or not responding to conservative treatment. If there's significant muscle loss or dense nerve loss, nerve sensation loss. The treatment options for this are open or endoscopic release. And usually this is, which approach is a conversation that's had between the surgeon and the patient. Endoscopic is where we use a small camera. It's inserted before the carpal tunnel, and we use a small blade to cut the ligament from the inside without going through the palm. Whether or not it's open or endoscopic, the recovery is essentially very similar. The sutures come out at about 10 to 14 days, and we start therapy to maximize functional outcome. Recovery for this may take months, especially if this has been going on for years. But the recovery and prognosis after surgery is very reliable. 90% of surgically treated patients report satisfactory results. I believe that number is even higher. The most reliable thing that we can state is that burning nighttime pain goes away the day of surgery. For cubital tunnel syndrome, this is in which the ulnar nerve is compressed at the elbow. This is often shown with loss of strength, dexterity of the hand, numbness in the ulnar 1.5 of the digits, the small finger, ring finger. Pain, weakness, and deformity are usual late findings in the hand. These are aggravated by elbow flexion. Compression of the nerve at the wrist is very uncommon, but it's something that we have to look for. It is usually just caused by what we call idiopathic, or it just occurs. But there are other reasons for that we have to address for. This is due to pressure of the nerve at the cubital tunnel. Sometimes it's associated with movement of the nerve that we assess with whether or not this is staying in its groove. And oftentimes patients will state they've been flexing their elbows for a long period of time during sleep, and that reproduces their symptoms. Examination is key. We look at percussion of the nerve and whether that reproduces symptoms, flexing the elbow, as well as specific findings in the hands and specific tests. The bottom pictures are usually late findings associated with this issue. Oftentimes, we'll recommend a nerve study. This is to establish the diagnosis and prognosis. Treatment options are usually conservative. This will be in the form of avoiding activities such as flexion that it's aggravating the nerve splinting the elbow at nighttime and extension, elbow pads that limit irritation like bumping your funny bone, anti-inflammatory medications. This is effective 50% of the time. In terms of surgical release, we make an incision, release the nerve completely at its possible compression points along the nerve, and if necessary, move the nerve to a better location if there's signs that it will dislocate or sublux, which means that the nerve is moving in its groove. And the recovery from this is highly reliable, 90% excellent results when the symptoms are intermittent. When there's atrophy present, where there's muscle wasting, it's less reliable, but it's worth the decompression. One of the other topics I'll discuss are masses and lesions. For the most part, these are benign, completely benign issues. Usually, skin lesions are more commonly associated with malignancy. These are still very rare. Location is critical. Again, these kind of form in very consistent areas. We'll talk a little bit about ganglion cysts, giant cell tumors, metacarpal bosses and bone spurs, warts, inclusion cysts, and masses. These are really common. Ganglion cysts are a huge portion of those soft tissue masses, about 70% of them. And these are lumps and bumps on the back of the hand or wrist or even palm. These are essentially balloons filled with a clear jelly-like fluid with a high concentration of hyaluronic acid. These are usually caused by trauma or mechanical irritation. They sometimes can be found associated with arthritis. On examination, these are firm or soft nodules that are tender sometimes, and they get transilluminated, where we flash a light through it, and you could actually see right through it. Mostly these are on the back of the wrist. You'll sometimes hear that somebody took a Bible to it and ruptured it. On the front of the wrist are common as well. These are sometimes associated with arthritis or some type of issue at the wrist joint. On the outside of the wrist, it can be associated with that tendinitis called de Quervain's. In the palm and fingers, it can be associated with trigger fingers, as well as severe pain in the joints there. When there's arthritis, we often talk about mucus cysts forming, which are very similar. What I do not advocate for is this cartoon on the right, where someone's taking a needle with pliers and poking on the front of their wrist. This is a huge, huge potential problem, one for infection and one for, there's an artery there that may be causing, that could potentially cause a huge complication. For the mainstay, these are treated conservatively if they're painless, as they can spontaneously go away. Splinting, anti-inflammatories, and activity modification are useful. Sometimes in decades past, they would say just take what you call a Bible to it and just rupture it by snapping it. The problem with that, as well as aspiration, where we put a needle into it and take it out, is that these tend to recur. And recurrence in the aspiration, if we take the fluid out with a needle, can happen probably more than 20%. That's what's listed in some of the literature. In terms of operative intervention, severe pain is what we do this for, as well as severity of the, as well as oftentimes the dimensions of the lesion. We remove the cyst in its entirety, and we go down to the stalk where it's occurring and close that off. The recurrence rates are low, less than 10%, probably even lower than that in a hand surgeon's experience. Giant cell tumor is very common. It's a completely benign issue with no metastases, but it can recur. It usually happens on the palmar aspect of the hand, but it can happen in the digits and on the back of the hand. These are firm masses that can also affect bone, but they're completely benign. And so the treatment for this is excision on an elective basis. These do recur about 5 to up to 50% of the time in some literature reports, and they usually recur in higher percentages if it goes into the joint or involves the tendon. And that's treated with just repeat excision. Another common issue is an epidermoid inclusion cyst, very common benign issue where after a trauma or puncture of the skin, there's a cyst that forms. And this lesion does not illuminate with a flashlight. And the excision of this is curative. So with that, I think we covered a lot of bases, a lot of kind of common hand and wrist injuries. A lot of information. I'm happy to answer any questions you have, and I thank all of you for sticking around for the presentation.